Greetings, Abnormal Psychology class. This is the first in a series of mini lectures. It'll be about 10 minutes, 11 minutes, something like that, to go over the basic outline of each of the remaining sections that we will cover for the course. The one that we're about to hit is the Somatic Symptom and Related Disorders section in the DSM-5. And these are a collection of things such as somatic symptom disorder, illness, anxiety disorder, conversion disorder, factitious disorder, malingering, and so on. So a few things we will leave out, but we're going to hit the good ones. Okay, I'm going to have to go fast. We don't have a lot of time left in the course, so let me go on and get going. So all of these disorders suggest, upon presentation, that there may be a physical disorder, medical disorder, but the symptoms cannot be adequately explained medically or biologically or physiologically. So often, but not always, but often, the symptoms that people bring in are offered in very dramatic ways. There are many other comorbid conditions, including things like personality disorders, anxiety disorders, depression, and so on. Okay, so that's kind of the basics. In terms of somatic symptom disorder, we're really talking about disproportionate and persistent thoughts about the seriousness of symptoms that they have that are physical, okay? And they cause a lot of problems, as do all of these, obviously, in terms of their own functioning and in terms of relating to other people. They have a lot of anxiety about this, and so there is generally a 6-month window that's required. You have to have these symptoms for 6 months, and the symptoms are marked by a real impairment. Okay, so we're really talking about typically predominant pain, not always, but typically predominant pain. Now, if you think this is about what illness anxiety disorder is, it's different. Illness anxiety disorder used to be called hypochondriasis. That's what a lot of people still call it, hypochondriasis. But it's not that. So hypochondriasis is different. Even though both have extensive worries, in hypochondriasis, the physical complaints are extremely minimal. Okay? And so a hypochondriasis person is excessively worried about little tiny things that are normal. So they have a little acid reflux after eating something really spicy, and now they have a tumor. Okay? Somatic symptom disorder is more about having ongoing, not switching around all the time, pain, often abdominal or genital urinary. And so it is different. Now, they're not faking the pain. The somatic symptom people are not faking this. Okay? This tells us a lot about the degree to which the mind is operating on our bodies, yes? So, what do these folks do in addition to hypochondriacal patients? They use a lot of medical resources, and so usually, so that's you may get a lot of patients that have been in to see primary care physicians who are using a lot of their time and energy, and they can't find anything wrong with them. And that doesn't mean something isn't wrong. The same with hypochondriasis. Doesn't mean something isn't wrong, and you always have to be vigilant for that, don't you? So the risks for all of these disorders really are within temperament. So we think about there being such a thing as negative affectivity. You've heard me talk about that when we talked about anxiety disorders. Okay, so neuroticism in general. And then some of the environmental risk factors include low socioeconomic status, lower education, and recent stressful events. So for somatic symptom disorder and hypochondriasis, often you'll see some very significant traumatic event that may trigger this, but there's an underlayment of genetically controlled things like temperament, okay? Or a pre-existing comorbid condition, such as certain anxiety disorders. This used to be called hysteria. Go figure the misogyny associated with that, right? It was called hypochondriasis for a while. Melancholia. In the 1800s, it was called Briquet's syndrome, a French guy. And then the DSM-3 in 1980 first labeled it and called it somatization disorder. And soma means body, so this implies that the body is being acted upon actively by mental processes, okay? And then the DSM-5 changed it to somatic symptom and related disorders, so collecting various things, yes? So prevalence, 5 to 7%, but much higher in primary care physicians. Onsets before 30, often chronic in its course. Difficult to treat. Stress management, social skills have been going on for a while, because as you know, social skills erode. When you've got any psychological set of issues that limit your interaction with people in any ways that are typical. Yeah. A little bit more about hypochondriasis. So concerns again for 6 months, but you can have people who are very care-seeking in hypochondriasis, so they use a lot of medical resources, or you can have what's called a care avoidance type. And the care avoidance type are the type that they still have this anxiety about something being wrong with them and are constantly going from one thing to another. First they have a tumor, and then they have the headache, means they have a tumor in their head, or oh my God, I've got this, and I've got lupus, and I've got... So they're constantly flitting about in what they think is wrong. They may think they have lots of things wrong, and often do, but they don't. But they're afraid to go to the medical folks because they fear what might happen if they do that. So there are two different groups of that. Typically, they are more medically seeking. So again, there's no physical symptoms verified by examination, not medically valid stuff. And they even if you give them reassurance, it does not work. The reassurance does not work. Okay, so what they're basically doing in hypochondriasis is they're over-reporting typical bodily sensations. Okay, all right. Prevalence varies depending on the survey, and the epidemiological catchment data is a little bit wacky here, somewhere between 1.5% and 10%, something like that. All right. Again, major stressors can occur that trigger this, but there's this emotional reactivity that they have. This negativity and neuroticism is often common as a genetic thing, temperamentally, and then there may be serious childhood illnesses. You may see that with people who have hypochondriasis. Okay, so how do you treat this? Very difficult. It also often runs a chronic course. It may go away for a while and come back and go. So sporadically returning chronically. Cognitive behavior therapy is number one, as it is with all of these. Substantial and sensitive reassurance, not telling them that it's all in their head. But here's the thing you can do is stress management. Because all of these folks have, in any of these disorders, lots of anxiety. So what you want to do is give them some control over the anxiety that they feel. Okay? All right. Conversion disorder, which will eventually be called something really fancy. It'll be called, let's see if I can remember, functional neurological symptom disorder. And that's fancy, but it's going to be called conversion disorder for a long time. This means that in reality, the anxiety you feel about something you've experienced, something you're in the middle of, something you're concerned about happening, provides that you can't function doing that thing that you were doing. And what it does is, it being your brain, it makes you lose a function, actually lose a function, lose your eyesight, start having seizures, pseudo-seizures, anesthesia, in your extremities, all sorts of things can occur. In your PowerPoint, I have a very useful video to tell you about this disorder. A woman with conversion disorder having what some people would look like seizures, but you can tell they're not seizures if you look closely. So see if you can see that and tell. And then we get to the last one, which is factitious disorder. Factitious disorder is actually deliberately, knowingly, your brain isn't creating a physical thing, knowingly creating false symptoms to get attention. So you will often find injuries that only the dominant hand or a hand could get to, and you'll never see it where the hand can't get to. Or the person may have all sorts of things that they do to get medical attention. So they'll hurt themselves to get to the hospital, present to an emergency room, because that's where they feel the most cared for, is in the hospital. I know, it's odd, isn't it? It's very odd. We don't know how many folks are like this, but they may, in a chronic way, continue to do this and may up the ante and do more dangerous things to themselves. But there's another form of this that probably shouldn't be in, at least I personally don't like where it is in the DSM-5. It's called factitious disorder by proxy. These used to be called Munchausen syndrome and Munchausen syndrome by proxy. This is actually child abuse, where a child is intentionally injured or coached to present in malignant ways to the medical facilities. So this is actually child abuse. And parents will actually even smother the children sometimes and say, God, my child has stopped breathing. And when this kind of thing is suspected, they'll put them in a monitored room, a video monitored room. So it's hard to tell right away, but you'll see what's called a positive separation test, where the parent really, once the parent is not there for any extended time, the child doesn't have the symptoms anymore. Anyway, there you go. Talk to you next time. Look at the question that's being posed and answer it, because it's required. Bye.